So I'd like to welcome you today to Breastfeed Durham's very first food equity series that we're putting together. We're going to meet once in October, and then we're going to continue on the second Tuesdays at noon in January. And we have a lot of exciting speakers that we're lining up, and you'll see more about that in email. And we really were passionate about doing this because we've been wanting for 2 years to have a conversation about first food equity. And we love this idea of it being a shared responsibility. That's part of our mission and vision at Breastfeed Durham, that we look at how all of the pieces of the community are connected. And we wanted to really build on this idea of first food equity and the 10 steps to breastfeeding success and expand that beyond the hospital, because those of you who are local know that Duke's been working on baby friendly for a long time, but it's more than just the hospital. We want the 10 steps of success to extend into the clinic. And so there's a lot of designations here in North Carolina. In case you've never looked at the designations before, there's the hospital ones, and the North Carolina Breastfeeding Coalition has designations as well for hospitals. And they also have designations for clinics, the Mother Baby Friendly Clinic Award. And Breastfeed Durham is based on the 10 steps to breastfeeding success and the 10 steps to a breastfeeding family friendly community. And we've created a local designation that's a stepping stone for the North Carolina Breastfeeding Coalition's designation. And we warmly welcome all of you to apply. I'm going to put the link to my slides in the chat so that you can go ahead and feel free to click on those links if you need it. And then Breastfeed Durham, we are a community-wide program, and our goal is to connect more than just healthcare, but to look at all areas of business and of the community. And we often talk about how we have this conversation around first food equity, and it also often feels heavy on the shoulders of healthcare providers. But we at Breastfeed Durham know that we all have a role to play in this work, and it truly is a shared responsibility. So know that we are not just bugging you healthcare providers about this issue. We are also talking about to the Chamber of Commerce, we're talking to pharmacists, we're talking to the Better Business Bureau, we're talking about signage with Parks and Rec. We are looking at faith-based communities and business owners, looking at a full spectrum way to support and normalize breastfeeding throughout the community. So at Breastfeed Durham, we envision a world in which parents and families and babies leverage their expertise to transform the community. So we imagine what it might look like if our entire community was unapologetically committed to race equity and gender equity and equity across the board. We know that particularly women and our pink collar workers have struggled to achieve equity, and we still see that reflected in pay rates to this day. And one of the things that we're doing as we advocate for this change is also advocating for equal rights for our teachers, for our nurses, and for everyone across the board. And so we're implementing, I talked about this already, the 10 steps across the community. And one of the things we wanted to talk about was thinking about, as healthcare providers, we know post-opioid crisis that advertising affects all of us. And part of our request and the requirements of the World Health Organization is that providers and offices purchase all of the formula that we use. And we know that that's a struggle for a lot of our clinics, and it's something that you're all working on. But we humbly encourage that each one of you talk with your institutions and your colleagues about moving in this direction over the next 5 years. And hopefully that can be one step on transforming systems. So I want to introduce Annie Dotson. She is from the Department of Family Medicine at Duke Hospital, and she's been doing some really transformative work talking about breastfeeding policy at Duke, and we really wanted her to come and share her experience as she goes on this policy development journey.
But we're going to talk about a little bit about writing a breastfeeding friendly policy. And I like to think of this as applying BFHI to the outpatient kind of world, the outpatient clinic, which Love so graciously kind of mentioned with the 10 steps for the the community and 10 steps for the clinic. This work has not been done alone. So I want to make sure Rebecca Casper is a resident that's been working with me on this and is here today. And I want to make sure to acknowledge that she has participated in this quite a lot, including a lot of the drafting of the policy itself. And she and I are both going to field the questions and discussion at the end. So just as a reminder to kind of refocus us about what are the 10 steps for BFHI, this is a really lovely infographic from WHO and UNICEF to just remind us of what those steps are. Remember, BFHI was designed really for the hospital setting, so really inpatient care around how we can make our inpatient experience more breastfeeding friendly, and specifically inpatient experience regarding like maternal admission for delivery and postpartum in the hospital. But many of these can also be applicable to the outpatient world. BFHI has wonderful data around really being an instrumental implementation tool to create health equity for our families around breastfeeding and infant feeding. Um, so looking at what are the critical time periods to support breastfeeding, some of us might say all the time points are critical, but really we can identify the prenatal period is a really critical point when families are making decisions about their feeding choices. Birth of the baby is really important after discharge, and then the supportive environment that really includes the community as well as support systems. BFHI really does a great job of incorporating tools for the prenatal period, as well as for birth of baby. And then we're left with these two other huge critical access points for breastfeeding that have a lot of good information published, but they're not under BFHI with your post-discharge and supportive environment outside of the hospital. Um, so what has been made available for to guide us in writing these breastfeeding friendly policies? California has a 9-step plan, and I've put the resource at the bottom just for your reference, and I think Love will make these available afterwards about what goes into being breastfeeding friendly in the outpatient setting. So one of them is a policy or a protocol, staff education, patient education, clinical services, as well as your clinic environment, your community resources. So, a really nice integration of our community being a critical point for breastfeeding support, workplace lactation accommodation, meaning how are we supportive of our employees, financial sustainability for a breastfeeding friendly clinic, and then what are we doing with quality improvement and impact evaluation. Colorado published a 6-point plan for breastfeeding in medical offices. And with that included a policy, provider training, patient education, our clinic environment, evaluation, and sustainability and continuity of care. So we're seeing some similar theme with California's 9-point plan. Um, this is pulled from the Colorado plan, which I think is pretty well known in the space of writing breastfeeding friendly policies. And they really divide up when we're talking about, as one of their 6 points, when we're talking about a policy development, what does it look like for a clinic that is progressing towards writing a policy? What does it look like when a policy is breastfeeding friendly? And then really striving for what does it look like when we're breastfeeding advocates? And I think that that's a really lovely way to distinguish. We should all strive to move towards that breastfeeding advocate space for all of those points. Academy of Breastfeeding Medicine, in their Protocol 14, published many steps to what it took to be a breastfeeding friendly physician office. And I think it's really lovely because it really outlines really clearly all of those components. Some of them are similar in terms of repeating from the other plans, but a policy as one, staff education, following WHO International Code of Marketing of Breast Milk Substitutes, which we're going to talk about in just a minute, understanding your local and national breastfeeding laws, promoting breastfeeding in the office, as well as with that, normalizing breastfeeding. Considerations when providing prenatal care, and then the postpartum immediate care, as well as bridging postpartum care to the outpatient setting. making a collaboration between disciplines, meaning recognition that there's multiple providers when we're talking about breastfeeding dyads, or even more than that, depending on how many infants there are, and what that takes to really promote and collaborate with those disciplines. Patient education, provider education, as well as collecting data. When we're talking about where did we start, so part of our process was thinking about all of those pre-existing resources that we have available for what does it look like to have a breastfeeding friendly policy. I would say the most important place to start is making sure your clinic is following the International Code of Marketing of Breast Milk Substitutes. And as Love mentioned, that is really important both from a community level, hospital level, as well as in the clinic setting. And I think this is the foundation of moving forward with a breastfeeding friendly policy within an outpatient clinic setting. We were really lucky in that our clinic really was already following this. And so it didn't take a lot of convincing that this was an important place for us to be in as a clinic. But I think depending on your clinic setting, that might take more effort to really implement the code, because implementing the code, I've kind of broken it down into there's many points in implementing the code if you look at the published materials by WHO, but really it comes down to purchasing formula at cost, meaning not at discount, not promoting artificial feeding in the literature that is available to your patients. Really, this is most important when you're talking about magazines, any printed materials that patients have access to, whether you're providing it or making it available for them to read in your waiting area, really needs to be free of marketing for formula. That can be really challenging when we think about parenting magazines that often have promotion of artificial feeding in their content because they're often sponsored by formula companies. Not providing patients with free samples. And I would say, there are ways that we sometimes have to work around that one in particular. The free samples really was written as a way to not be providing parents samples for unnecessary reasons. We're going to talk about later that there are medical indications sometimes where we have to do artificial feeding, and using a sample and that means if you're paying for that sample is different because you're actually supplying your formula at cost, not getting a sample from a formula company and then giving that sample to a patient. Not having gifts sponsored by formula companies is really important. So similar to those welcome bags that parents get in the mail from formula companies, we don't want to be supplying those to our patients. Not having sponsorship or relationship with formula companies is really important. And then providing factual information, particularly around artificial feeding and the benefits of breastfeeding. And then this is just an excerpt from the code itself, mentioning part of the code is to contribute to the provision of safe and adequate nutrition for infants by the protection and promotion of breastfeeding and by ensuring the proper use of breast milk substitutes when these are necessary on the basis of adequate information and through appropriate marketing and distribution. And so you can see there is a recognition that there might be times where you do have to use formula artificial feeding mechanisms, but those really should be supported by medical indications. And so for those of you who are not currently following the code in your clinic and are struggling with where do we start, I always like to think of the idea of what are the reasons to not follow the code. I've heard many from other clinics that are struggling with this, of how do we work around this one area. I really think it's the foundation of how you move forward. And once you get your clinic on board with following the code, then the lift is a lot easier. So what are the reasons that people within your clinic, that leadership within your clinic is pushing back, that they don't feel like they can follow the code? And I'll leave that for your own thoughts of what that might be. So once you follow the code, then really I break it down into there's 4 things that are going to move us forward towards making a breastfeeding friendly policy. Because really the policy is a reflection of what's already happening in the clinic. It's not where we start, right? It's really our end product. And so once you are following the code within the clinic, then thinking about your clinic environment, education and training as a whole, layers of care that are provided, and then data for sustainability. And I'm going to walk through each one of these. So thinking about your clinic environment, these are some examples of some posters that we really like in terms of reflecting breastfeeding in a variety of patients and backgrounds and being culturally respective and normative. And so I think thinking about what do patients see? What's their experience as they walk through your waiting room, as they go into the restroom, as they walk through your clinic hallways when they're going to a room? And then what does that look like in the room itself? And do you have information available on the walls for patients to see that does promote breastfeeding and does not promote artificial feeding mechanisms? The other ways that we can think about our clinic environment is thinking about what space is available for our families, our lactating parents. Is there a private space where families can choose to breastfeed? And this is an example on the left of a space that might be available. In this space, there's a pump available. Do you have a pump that patients are able to use? This is a hospital grade pump that would be multi-user, so it would be safe for many families to use. Does that space have a sink? Does that space have supplies if needed? Does it have information? And you can see on this bulletin board, there is space provided information on breastfeeding. And this is not from our clinic. We're all striving to have this kind of space available. And so, is there a private space? What happens in the waiting room? Are parents encouraged to breastfeed their children in the waiting room? Are they asked to cover up? Um, we want to respect all families in their comfort for breastfeeding. So those families who do feel comfortable feeding in public spaces, how do we promote that? Meaning, how do we include our front desk staff to encourage that practice for families? Do we have comfortable areas for families to feed? And then the last piece is, where is formula kept? As we talked about, there are medical indications where we do sometimes need to use artificial feeding with formula for a variety of things. And so that isn't something that we might have that in our clinic. We have it in our clinic. We do pay for that at cost for our clinic. But where is it kept? Is it where a patient can see? Or is it kept under, we keep it under a lock and key, so that it's not freely given out. It's really given out for medical indications. So thinking about, where is formula kept? How is it accessed by the staff? How is it accessed by patients? And what does that mean for the promotion of formula? And in that case, not following the code. And then, what does the clinic environment look like for our staff? We have lactating staff. Do we have a space where they can feed that is private and accessible? Do we promote feeding within our clinics, meaning allowing staff breaks to actually lactate? Do we allow families to bring their children to lactate if they choose to? What does that look like? Because the clinic environment is for everyone within the clinic, patients and staff included. And then our next part, what about education and training? And I really think of this from the provider, and I'm going to include provider, meaning all of those personnel who interact with patients. So that might mean the front desk staff, that might mean CMAs, MAs, nurse, and then physician APPs, all providers that would interact with patients. And then there's the patient. So when we look at the provider goal, we're looking at a goal of 80% of our staff and providers have some amount of education related to breastfeeding. And I'm going to show you what that looks like depending on who the staff or provider is. There are many free resources available to actually provide education and training to our staff and providers. And so I think that's really reassuring that we don't have to create that educational tool. I think the the hardest thing is we really do want our providers and staff to have annual training, and that can be complicated in how we roll that out. And we'll talk about that as one of the challenges that we have also faced. Our education, we really want it to be culturally competent and to encourage that there are different cultural norms around breastfeeding and what that might look like. And so integrating that is a really good opportunity for our providers and staff. Some topics, this is not in any way all inclusive, might be talking about infant feeding plans, medical indications for supplementation, and options for supplementation. When we're talking about patients, we're really want to be starting in the prenatal period. That is endorsed by BFHI as well. This might include classes, resource sharing, any number of ways to have an education for our patients. We use Ready Set Baby at Duke and within Duke Family Medicine, which is from UNC. And so it's a really great system that starts in the prenatal period. So thinking about what would it be like for your patients as they also get education around breastfeeding through their prenatal period. This is a look at what is from the Colorado 6-point plan in terms of how we would roll out breastfeeding education by trimester. So if you're an OB family medicine office where you're having patients in the prenatal period, what would that look like in terms of providing breastfeeding education across trimesters? And then for those of us taking care of newborns, family medicine, pediatricians, what does it look like to have breastfeeding education in the postpartum period, even in our newborn visits and our well child checks? And so this is also from the Colorado 6-point plan. I like that it matches up with when we expect that we would see newborns in our clinic through 9 months and how we can provide education across those 9 months in a strategic way to actually have comprehensive breastfeeding education for our patients. And this is really by topic. So thinking about, are we really educating our families on these topics? Thinking about then layers of care, what does that look like? And so we talked about there's the prenatal period, there's the intrapartum period, and then there's the postpartum period. Most of the intrapartum period or really hospitalization period is going to be following BFHI. When we talk about prenatal and postpartum, those are really areas that we have for impact. And so in the prenatal period, we have a good opportunity to think about identifying risk factors for not meeting feeding goals for our families, and then connecting our families to prenatal consults. When we talk about postpartum, we're talking about triaging and encouraging feeding, and then referrals and resource sheets if needed. And I put down here, what does it look like for patients to navigate through a referral process? Typically, patients would see their primary care provider, whether that's a family medicine, OB, pediatrician, and then would be referred to a lactation specialist. That might be a CLC, might be an IBCLC. There can also be peer counselors, any number of layers within the lactation specialist. And then if there's really more medical management that's needed around breastfeeding, thinking about seeing a breastfeeding medicine specialist. So do you have a referral process for your system, your clinic, or do you have a way to connect your patients to resources that are needed if they arise? Because those are things you don't really want to be thinking about when it comes time that a patient needs it. You want to have a plan in place for those patients. And patients that are breastfeeding will call. How are you going to triage them? Very, very important. So thinking about, these are both from UNC, and UNC has some really lovely resources. I've put on the right, Mom Baby Org is a really lovely resource which talks about a number of triage protocols, as well as protocols for complex nipple pain, radiologic image, things that come up during breastfeeding and how we can manage those. And then on the left is an example of their triage system. So again, we don't have to recreate this. We can also modify it for our system that we're in, which is what we've done, and implement it to fit what we need for our clinic. And so thinking about if your triage system is going to receive a call around nipple pain, what is going to be the process in place to have good follow-up, timely care for that patient? This is also an example of thinking about how we kind of diagnose different issues with breastfeeding, what our action plans can be. This is from Dr. Milk, which is a group of physicians online, and talks about risk factors for moms and for babies, as well as expected feeding volumes. So normalizing the volumes for our infants, as well as what our expected voids can be, and then normalizing some resources that can be available to patients at that 3 a.m. when we're really struggling, and what can we do to support those families. And so this is not by any means comprehensive in terms of what's available. There are a number of things available, but I think it's nice to kind of see what has already been developed that we might be able to utilize. And then this is also from UNC, thinking about if a patient is coming in, maybe we do have an IBCLC at our clinic, and how can we have better communication between IBCLCs and providers in our clinic, and creating a system where we really see what the next plan is in place, kind of being more systematic about where a patient is navigating through our system. And so thinking about what equipment might have been provided, what the problems are with feeding, and this divides it into mom and to child. And I think that's really nice, recognizing that there are two or more in a feeding relationship, and then prescriptions, referrals, tests, supportive care, really getting everybody included, and what is the plan moving forward for this dyad. And then data to promote sustainability. This is more of a, I think it's really, really important for us to track our breastfeeding, and what our rates are. I think how to do that is extremely challenging. And so always room for improvement, even from our clinic. This is something we're now navigating, is how do you really track that in a way that is reflective of your clinic population, right? Knowing the health system is really important, but you also really want to know how your clinic is doing, and how implementing a policy might also improve that exclusivity rate. And tracking that through EMR can be very challenging. So I leave this as a food for thought, depending on your EMR system and your tracking. But it is important for us to know how our rates are looking in our clinic, so that we can continue to improve and progress with our policies. And then Love mentioned this, I think this is really important, is clinics are part of larger communities, right? So really working with your community networks, your community agencies is really important, and engaging with them, because they're doing a lot of phenomenal work, as Breastfeed Durham is doing. And so thinking about shooting for that goal of empowering our communities to also have breastfeeding friendly clinics. And so we really want to create that system where that sustains itself and is supported by our communities, rather than us only doing it from the healthcare system. And so thinking about how to engage with the larger community, I think, is really important for our long-term longevity of the breastfeeding friendly clinic. And then one of the things we really learned about a lot was stakeholder engagement. And we talked about stakeholder engagement in the previous slide with the community. There's also stakeholder engagement within our own clinics, which is really challenging. And so thinking about who are the stakeholders in your clinic that are going to have to be on board with a breastfeeding friendly policy, incredibly important. So thinking about patients, definitely our stakeholders, providers, nursing staff, front desk staff, clinical operations leadership, depending on how your leadership team works, or your directorship within your clinic, and then other staff. Do you have x-ray, lab folks, referral coordinators? Who's in your clinic, and who's going to need to be supportive of this policy? Because really we want this recognized as a whole clinic move towards being breastfeeding friendly. And we want everybody to be on board with that, so that we can give the patients the best experience with their feeding in our clinic. And then I want to mention, last year, Academy of Breastfeeding Medicine published a position statement on gender inclusive language. And I think that it's really important. We've tried to incorporate this within our policy as we're developing it, using terms that are like human milk feeding where appropriate. And so I think thinking about how does your policy also include gender affirming language, and really supporting all parents who are lactating. Some of our challenges, which I'm happy to talk about more when we do our discussion, has been, I think, stakeholder engagement, especially when you're working within a larger health system. I think that that's really challenging. Also within a clinic, there's a lot of, as it relates to the next point, a lot of competing priorities. There's a lot of things clinics are trying to do. So really encouraging them to focus on feeding as a way to focus on our families is challenging. Many people within our clinic have been excited about breastfeeding, but is that a priority then? I think that can be the challenge depending on your setting, because we're all trying to create agendas, and really prioritizing feeding can be hard depending on your situation. Creating a structure that enables sustainability, that is really challenging. Part of that is going to be having your data to create sustainability, but also creating your networks, right? Within your clinic, within your health system, within your community. That's what's going to create sustainability. It can't be all one person. And so how does the policy, the breastfeeding clinic, sustain itself? And really getting that buy-in, that stakeholder engagement to start with is key. And then, as with anything that's a policy, navigating systems is complex and that takes time, always more time than you think. And so I think really being in there to, for the long run is super important as we're learning, because it's hard. These are some resources from Love related to policy development. And then there's some other additional ones in the PowerPoint slide, but there's lots and lots of stuff published. So don't feel like you're creating this alone, and really a lot of things to lean on. Thanks for having me.
Do we have any questions?
Hey, Love, this is Gabby Maradiaga. Hi, everyone. Thanks so much for having this conversation. Can y'all hear me okay?
Yes.
I wanted to share, and this just goes to show how things can, in a big system, it's still important to keep connecting. The point that Annie made about data and having really good data to understand the lay of the land and to support changes. So we went through this at Duke Children's Primary Care in 2016, and we created a tool in our EHR system called Milkbox, which actually is an excellent way to capture data, and it can be automatically put into your notes and templates, and it's available in Epic for any other system. So UNC or whoever uses it can be used too. I'm happy to forward that along, and Annie, we should chat about Milkbox, because it's been a great way for us to look at our rates, and we even published a paper on it. So happy to share that with anybody who has Epic and is interested in a already existing real-time breast or milk feeding type tool.
That is awesome. I love that. I love solutions that fit into Epic. That's exactly the things that we're looking for.
Hi, this is Ellie Erickson, also from Duke Children's Primary Care. I had a question about the formula payment requirement, and just that is kind of where we have come up against issues with our group. We have a very diverse and very medically complex population, and whenever we have this conversation with our with our kind of leadership team and clinic team as a whole, again, I think your point about clinic stakeholders is really important. We cannot get good agreement on the formula part and paying for our own, and because we have so many families with such great need for formula. So I would just love to hear more about your experience in crossing that bridge and what that was like for you guys.
Thanks, Ellie. Yeah, I've talked with many people at Duke Children's about this. Yeah, I think that's bringing back to like, what is the real concern? Because I think from different people, you might hear different things. And so really asking all the stakeholders their concern, I think, is really important. For us, we serve about 80% of our prenatal patients, and then it extrapolates to even more when we're talking about our newborns, are Medicaid. And so I think we are very good about making sure our patients are connected with WIC, which I imagine also is the case for you all. And I have heard from other folks, it's like WIC supplies much of the formula, but it can be challenging to supply all of the formula. I think there are some other options in the community that can provide that support without it being from the clinic. And so there are many groups in the community that focus on mothers and kind of mothers groups. I think that it just doesn't need to come from the clinic is the most important thing. And that's what I would push back of, like, where is that appropriately positioned? If WIC isn't able to supply the full needs of the family, then what would be the alternative besides it being from the clinic? I think with medically complex children, that can be a little different because we're talking about potentially having to try several different formulas, and that becomes very challenging with WIC because of they really want a prescription, but if you don't know if it's going to work yet, it's hard to supply a prescription, and then they're getting a formula they might not be able to use. I think in that case, there's still the ability, like we do provide some formulas, but under the medical indications, but we're buying it. And I think when we started doing that, there was some pushback. People thought that we were going to be paying a lot of money for formula because we would be giving it away, right, for medical indications and things. I will say, I purchased formula a year ago and it expired. That's how little we gave out, actually, the amount of formula. So probably about half of it expired just by sheer virtue of we didn't have to give it out. And so really shocked at actually how much do you medically need to give out versus what we think. Because right now we're giving it out because we have it available. We're getting it at discount. You're giving it away because that's like, we're just giving it out, right? You might as well give it away if you've got it. But when you're thinking about true medical indication and supplying that, I think it's going to be a lot less than you think. So just pushing back of like, where can we lean on the community to supply the extra formula if patients aren't getting enough from WIC? And then if we're giving out medical indications for formula because there's medically complex children, then I think it's going to be a lot less than we think it is.
Thank you. That's super helpful.
Annie, that's shocking to me that it expired. I'm like, wow. So this is what happens when you go down that journey of starting to normalize breast, chest, and human milk feeding throughout your clinic. That is amazing. Amazing. And I mean, I'm very passionate about this subject, especially I don't know if any of you have done deep reading about the opioid crisis, but we know that all of us in our country are greatly influenced by advertising in really subtle ways. And that the rise of formula use in this country was driven by advertising and marketing. And I truly believe that removing that will begin to start to solve some of the health inequities in our community. So, but I also know that you can't do it by yourself. Like one good intentioned provider in a practice is not enough to turn the ship, right?
Sustainability,
yes.
That is key.
Yes. And I put all of Annie's slides they're all together now in the link that I already put in the chat, so that you can all see Annie's slides and the Breastfeed Durham slides all together. And there we go. So I just wanted to take a moment and share some resources that we have on the Breastfeed Durham website. I'm going to actually just flip over here, and can you see the Breastfeed Durham website? Give me a thumbs up. Okay. If you go to the Breastfeed Durham website, all of our resources for community members that are not necessarily lactating yourself are all under this tab of welcoming atmosphere. And we have one for healthcare providers. And here at the home, we've got the main page, but we also have extra tools for healthcare professionals. We have special tools developed for healthcare providers by our LGBTQ plus human milk feeding committee. But I really encourage all of you to look at them, even if that's not the space that you primarily served. I, as a peer-to-peer support provider, was really transformed when I dug deep into this and started learning more about how to assist people with inducing lactation. And I found that a lot of the parents I work with, from adopted parents to just parents with low milk supply, could really benefit from a lot of the resources. This is proof breastfeeding saves lives. This is where we put all of our great research papers that we come across, talking about the data that supports breastfeeding, and learning opportunities is right here. And we'll put the video recording of this meeting up on that place, as well as other things are there. But I'm going to just click on the main part and talk about I like a little personal campaign to get one day we are going to have a clinic in Durham that is going to apply for the designation to be designated a breastfeeding friendly physician's office or provider's office. So we have all the tools, a lot of the ones that Annie already talked about. The links to the Colorado 6 steps are in here as well. And one of the things when you put in your information, you have to upload a sample policy. And so one of the things, we're going to add a link after today. I wanted to hear what Annie had to say first, to our sample policy, which is right here. I'll go to the top, and there's a link in the slide deck, so that you all can just click on and view the policy today. But we will upload it to the website after we finalize it, because I wanted to, take this opportunity to put it together. It's long, because the policy, a lot of the providers in the community, the policies that each one is developing individually, many of them are short and a lot more concise. But because we're Breastfeed Durham and we've been assisting a lot of clinics and offices that are still remaining nameless and working on their policy, and no one is ready to share or get it posted yet, I just I asked everyone, I'm like, can I have it? Can I make you anonymous? And so I put it all together. And this is what we have to share. So if you're thinking about developing a policy, we really encourage you to take a look, to dig deep. It still has our notes at the top of what I'm going to put on the top of the website, and our sources. There are the links right there of everything that I just talked about in the slide deck. But I also wanted to say, if you're sitting there and you're like, no way, love, we're not getting this done at my office. We are not going to be able to put in place a policy. We are not going to be able to buy our own formula. That is not going to happen. Well, I wanted to talk about some low-hanging fruit. Signage welcoming everybody to breastfeeding. Annie talked about it, but I'm like, if you're looking for one thing to do in your office, put up some signs starting to normalize breastfeeding. I'm like, it's far away, but this is one of the signs that one of the posters Annie mentioned. And I was like, oh, I have that on the wall. It just starts to normalize the situation. And a lot of healthcare providers haven't actually heard about the NC Making It Work toolkit. They put together a lot of resources for the target audience as parents, employers. But if you click on this link, I'll just click on it. It's got lots of stuff. Videos, but it's got resources for employers. So if a parent is struggling to be able to pump at work, there's resources. But this actually also it's got advocacy stuff, which maybe is too much for many parents, but it's also got resources that's just here's a booklet for a parent who's going back to work, who's lactating, who doesn't know what to do. And here are all the resources that parent needs. And it's in Spanish and English. So that's fantastic. And already pre-developed resources. If you see a parent and maybe an auntie or a grandma come in together and the support parent's not really as supportive as you would like to see, if there need to be resources on how parents can support already made, beautiful, glossy, pre-made stuff. And so even if you're sitting in an office where you're like, there is no way we are going to be able to put in place a policy this year, or I'm going to talk to people about paying for formula, but that's a long-term goal. That's not a short-term goal. At least thinking about sharing these resources, as well as, I don't have them. Maybe Bernadette can grab them. She's here with them. Breastfeed Durham rack cards. Our goal is to have funding, and thank you so much for all coming here and signing in the chat, because we are very close to achieving funding. We're still in contract negotiations, but we are so close. And one of our goals is to be able to mail you all rack cards with breastfeeding information as well. And I just wanted to bring it back and say, I know it's heavy, but it's not all on your shoulders. We are not going to achieve first food equity until there's federal paid time off. I'm hoping that we might be able to add you all to our newsletter, because you'll see emails coming through with petitions from the United States Breastfeeding Coalition, from places like Moms Rising, that are working to be able to transform laws so that we're all supported, because we know this isn't all on medical providers. We all have a role to play in this journey. And then I just want to throw up email addresses. Email us, ask us questions. Breastfeed Durham is happy to assist in developing policies. We're always here for you. I think Annie is here to answer questions. And I just wanted to thank you all. Thank you all for coming. Thank you all for joining us. Annie, thank you so much for your presentation. And thank you, each and every single one of you, for all the work that you do to change our community and to help babies and families. Thank you.